Good evening friends, welcome to Packet Clinics. Today we are going to discuss about suspected case of poisoning, history taking, clinical feature, diagnosis, approach and management. Okay, fine. So here is the case of poisoning. A 20-year-old male farmer brought to emergency department after accidentally ingesting pesticide while working in his field. Within an hour, so go through the case. Within an hour, he develops excessive salivation, sweating and vomiting, abdominal cramps, diarrhea, blurred vision and difficulty in breathing. So what would be the most probable diagnosis? Can anyone guess? Can anyone try? So case of pesticide poisoning, excessive salivation, sweating, vomiting, abdominal cramps. Okay, any guess? Okay. On further examination, the pulse rate is 50. The 50 beats per minute. So there is a bradycardia. Blood pressure 90/60. There is a hypotension. Respiratory rate 30 beats per 30 cycles per minute. SpO2, that is around 88%. That means there is a presence of hypoxia and hypercapnia. Pupils, that shows meiosis, the pinpoint pupil, the classical feature of OP poison. So it's a case of organophosphorus poisoning. Bilateral wheezing with the copious secretion, that is bronchoria, that is present. Neurological examination, muscle fasciculation and generalized weakness. So what is the most probable diagnosis? Can anyone try? What is the most probable diagnosis? The most probable diagnosis is organophosphorus poisoning. Organophosphorus, it is an insecticide. It can be aryl phosphate or it can be alkyl phosphate. Like example, malathion is a well-known alkyl phosphate. Parathion, it's a well-known aryl phosphate. So what is the treatment and the diagnostic approach we are going to discuss in next 10 to 15 minutes. OP poison, a very common poisoning, especially as a suicidal agent. It can be accidental poison also. Remember, OP poison, it inhibits acetylcholinesterase enzyme. So it causes high levels of acetylcholine that stimulates parasympathetic system. The clinical features we can remember with the help of mnemonic sludge MTF, that is salivation, that is increased secretion because of the CNS stimulation. Because of acetylcholine, there can be convulsions and sweating. The sweating is a feature of activity of sympathetic system, but the neurotransmitter is acetylcholine. So common clinical features in OP poison: salivation, seizure and sweating. Lacrimation. Acetylcholine stimulates the lacrimal gland. There can be increased secretion from the lacrimal gland. Sometimes there can be chromodacruria. red color here, that is because of the presence of the porphyrins in the lacrimal glands. Urination, diarrhea, gastric upset, emesis. As I said in the beginning, meiosis very common. Mydriasis very common in case of datura poison. But in case of OP poison, the meiosis is very common. One of the differential diagnoses is morphine overdosage. Even morphine overdosage can lead to meiosis or pinpoint pupil. Tachycardia, in the initial stages tachycardia, later there can be bradycardia. Fasciculations, so all these are clinical features. So these are very important in history taking. And this is malathion, a well-known alkyl phosphate. The mechanism of action, it inhibits acetylcholinesterase. What is the function of acetylcholinesterase? Is the breakdown of acetylcholine into acetate plus choline. So when this reaction is inhibited, there will be high levels of acetylcholine which acts on muscarinic receptor and nicotinic receptors. So there are muscarinic symptoms and nicotinic symptoms because of high levels of acetylcholine. Okay. Now the treatment, the management. The treatment, try to memorize. The drug of choice is atropine. Atropine is a drug of choice in case of OP poison. Before that, there are some general measures. What are the general measures? One is the airway. Airway, very important because increased secretion that can lead to airway blockade and lead to death. And maintenance of proper breathing by intubation and other procedures, and to maintain circulation. In any poison, ABCD, A means airway, B means breathing, C means circulation, D that is drugs. Then remove the patient from the site of exposure, wash skin with the soap and water. So while treating, you must wear gloves because there can be transmission of poisoning, the OP poison, from the patient to the treating doctor or the medical professionals. If ingested, if it is ingested poison, that means the oral intake of poison, then perform gastric lavage. So gastric lavage is very important. Stomach pumping by using Ryle's tube in left lateral position within 1 hour or within 4 hours after the poisoning, up to 24 hours basically. The gastric lavage is contraindicated in case of corrosive poison, like example acid poison, alkali poison. So after doing a gastric lavage, you can also give oral activated charcoal. The oral activated charcoal is a physical antidote. It binds to the pores present on the stomach. It inhibits the further absorption. The dosage is around 1 to 2 gram per kg body weight. Say example 50 kg man, around 100 gram is given. Again, there are some contraindications, but both the agents, both the procedure, gastric lavage and activated charcoal, they are used in case of organophosphorus poisoning. So try to memorize this. This is again very commonly asked. Now I said the drug of choice, atropine. Why atropine? Atropine is basically It inhibits the action of acetylcholine. It's a parasympatholytic agent. It acts on all the receptor, muscarinic receptor and nicotinic receptor. It is going to decrease the signs and symptoms, and it is life-saving. What is the initial dosage? Initial dosage is around 1.8 to 3 mg IV. So 2 to 4 mg IV it is given. Review after 5 minutes. Look for signs of atropinization. Then again, what are the signs of atropinization? The earliest sign is pupillary response. So there will be pupil dilation. All the secretions going to be decreased. The airway going to become dry. The chest is going to become clear. That is the indication of therapeutic stoppage of atropine. So this can be asked in your exam. The earliest response is pupillary response. The confirmatory sign to stop atropine is dry secretion, dry chest. Now, if yes, then you can give maintenance dose 10 to 20% of total initial dose over 1 hour IV infusion. So 10 to 20%. No, then you can repeat IV bolus with a double dosage. 2 mg, then it is 4 mg like that. Again, look for signs of atropinization. The same that repeats. Okay. Chalo. Now, what are the other agents used in case of OP poison? So the other agents are basically, you can see here, prolidoxime. The prolidoxime is basically cholinesterase reactivator. It reactivates the enzyme, that is acetylcholinesterase. It must be given within 48 hours. Within 48 hours. Because after that there will be aging. So if you give prolidoxime or diacetyl monoxime after aging, there can be increased signs and symptoms, or we can say exacerbation. So prolidoxime is cholinesterase reactivator. The prolidoxime and diacetyl monoxime, remember diacetyl monoxime has CNS effect. And these agents are contraindicated in case of carbamate poison. So very important question. What is the contraindication for prolidoxime and diacetyl monoxime? Your answer must be Oximes, that is basically carbamate poison, carbaryl poison. So carbamate poison, so there can be increased signs and symptoms when you give Oximes. Okay. Then comes what is the dosage of prolidoxime? Initial dosage 30 mg per kg body weight over 20 minutes. Maintenance dosage 9 mg per kg body weight per hour. Okay. One more drug that is very commonly used clinically in case of OP poison, that is basically diazepam. One more agent, diazepam. So I'll repeat again. Atropine, then Oximes, then the diazepam. So 1, 2 and 3. Okay. And remember, Oximes can reverse muscle weakness. The muscle weakness because of the cholinergic crisis, very common in case of OP poison, that can be reversed by Oximes, not by atropine. This is again commonly asked. Okay. Fine. Now look at this. So this is one very important clinical feature in case of OP poison. The answer is red colored here, which is known as chromodacruria. The chromodacturia is because of porphyrins. Porphyrins. Okay. Then look at this one more picture. The picture of OP poison. The classical presentation, increased secretions. What you can see here, froth. The froth can be seen in various conditions. The one condition is OP poison, opium poison. It can be in case of snake bite. Many conditions. Even in case of drowning. Okay. Chalo. The next clinical scenario related to the case, the same OP poison. Now look at the case now carefully. A 30-year-old farmer, agriculturist, was admitted after consuming organophosphorus pesticide. She presented with excessive salivation, sweating, pinpoint pupil, bronchoria. He improved after treatment with atropine and prolidoxime. This already we discussed. 3 days later, he develops 3 days. Try to understand 3 days. He develops difficulty lifting his head. So there is a weakness of the neck flexures. Drooping eyelid, that is basically ptosis, involvement of levator palpebrae superioris. Weakness of both the arms, difficulty in swallowing, dysphagia, increasing breathlessness. On examination, weakness, proximal muscle weakness, bilateral ptosis, respiratory muscle weakness is there. But no excessive salivation, no excessive bronchoria. What is the most probable diagnosis in this patient? The patient presented with the signs and symptoms after 3 days, after 48 hours, after 3 days, 72 hours. What is the diagnosis? Can anyone tell me? What is the diagnosis? So the diagnosis is very, very important. It's a very common cause for mortality, very common cause for morbidity in case of organophosphorus poisoning. What is that? The diagnosis is intermediate syndrome. Intermediate syndrome. The treatment in this case is supportive. It's ICU management. Remember, it occurs after 2 or 3 days. So this is very, very important clinical condition. Okay. Chalo. Now try to memorize intermediate syndrome in organophosphorus poisoning. Guys, try to memorize key points. Proximal muscle weakness. Proximal muscle like biceps, triceps, leg muscle, not the distal muscle. Point number 1. Cranial nerve palsy. There can be involvement of the oculomotor nerve. Oculomotor nerve supplies extraocular muscles, levator palpebrae superioris. So there is a weakness of the cranial nerve and the muscle supplied by them. Respiratory muscle weakness. What is the respiratory muscle? Diaphragm. Diaphragm supplied by phrenic nerve. C3, C4, C5 keep you alive. And respiratory failure is the cause of death. So treatment क्या है? Treatment है ventilatory support and ICU care. Atropine is not very useful in case of intermediate syndrome. When it is going to occur? It is going to occur after 24 hours, after 96 hours after exposure. What is the earliest sign? Earliest sign is neck flexure weakness. Try to memorize one more very important clinical finding. Look at this. In case of OP poison, if weakness occurs, signs and symptoms within minutes, within hours, that is basically cholinergic crisis. If it occurs after 24 hours, 96 hours, then it is intermediate syndrome. If it occurs after 1 to 3 weeks, then it is delayed neuropathy. We call it as opened neuropathy, organophosphorus induced delayed neuropathy. So try to memorize. This is very important clinical sequence in case of organophosphorus poisoning. Okay, Arun Patil, are you getting my point? So just to simplify everything, that today's session, the pocket clinics, one very common poisoning, that is OP poisoning. So try to memorize this. Just summarize everything. The common poisoning in casualty emergency medicine, especially in farmers, that is basically pesticide poison. In pesticide, there are hundreds: carbamates, organochlorines, organophosphates and all. Organophosphates are classified into alkyl phosphate, aryl phosphates. They inhibit acetylcholinesterase. They cause muscarinic symptom and nicotinic symptoms. Okay, then try to memorize sludge MTF, the mnemonic. Drug of choice, atropine. Other drugs, oximes and diazepam. Chromodacruria, very commonly asked. Froth. Froth can be seen in various conditions. I said already, organophosphorus, opium, snake bite and all, drowning and all. Then try to memorize intermediate syndrome, the proximal muscle weakness, cranial muscle weakness. Okay, so this completes today's session. So, and the last, I have a question for you. Look at this. Here is a video of a snake. We discussed in last class about the snake bite, types of snake and all. So here is a snake, very poisonous snake, which is found within the shoes. So be careful while wearing shoes, especially in rainy season. Okay, so here is the poisonous snake within the child's shoe. Be very careful while wearing. So can identify this poison, can identify this poisonous snake, and what type of poison is this? Come on, guys. Look at this now. It has a hood. Hood is there. Hood. Spectacle mark is there. And it's a very young snake. Hood, spectacle mark, large belly scales, large head scales, rounded tail, neurotoxic, bungarotoxin, ptosis. Can anyone tell me, identify this snake? ऋषभ परमर, बताओ ये क्या है? This is basically common cobra. It's a young cobra, very poisonous. Try to memorize. The venom is very toxic. The venom is highly concentrated. Even one bite can lead to death within 4 to 6 hours. Sometimes it will give multiple bites. Okay? And cause of death, respiratory paralysis. And the fatal period is very less. It's around 6 hours. So most of the clinical signs and symptoms, they appear within 2 hours. The broken neck sign, the ptosis, convulsions, paralysis, everything occurs within 2 hours. Paralysis will be completed by 2 hours. A person dies within 6 hours. So if he reach hospital within 6 hours, he is going to survive. Otherwise, he is going to die. Cobra, Sanjay Kumar, others. So this is basically, repeat again, try to memorize this. Common cobra, young cobra. This is very young cobra. Point number 1. Bungarotoxin. Alapidae. Neurotoxin. Fatal dosage 15 milligram. Fatal period around 6 hours. 6 to 12 hours. Again, depends on the snake. The cause of death, respiratory paralysis. The most common manner is accidental. The treatment of choice, ASV. So, ASV, the polyvalent anti-snake venom. Okay, the most common side effect of ASV is anaphylaxis. Anaphylaxis. Okay, so this completes today's session, a short session on pocket clinics, a case of organophosphorus poisoning and intermediate syndrome.